Hello, my name is Adam Kirking, and I'm excited to be here with you today to build off our earlier discussions related to risk, utilization, and supporting those potentially vulnerable patients. Today's discussion will drill into a common reason for a patient receiving that red patient classification. We'll discuss high or inappropriate ED utilization and how to best support those patients. For today, we'll talk about the previous high-risk discussions or review some of that information. Talk about the role of an emergency department in the care setting. Discuss how to identify those high utilizers and how do we take advantage of the information that's already available to us. Drill into the what versus the why. And this is the reasons why the patient is going to the emergency department as opposed to just simply a diagnosis or something that we would see on paper. Talk about other care options or how to best support those high utilizing patients. And then we'll do a quick review of the Care Direct platform, and that's that tool that you can go to pull those lists or access some of this information for yourself. So to start with the previous information that we'd already discussed, in our July session we talked about red patients and managing and supporting those high-risk patients. And for that discussion before, we focused on it could be a transitional care management visit, maybe trying to see that patient one or two more times in your clinic, potentially thinking about chronic care management, or even a disease-specific protocol like focusing on patients that have diabetes, and maybe more frequently bringing our patients with diabetes in for A1C checks, or potentially working to try and find a diabetic educator that can support your patients. We then really spent time reviewing the red patients and how that idea of some patients needing just a little bit more attention because they're slightly more vulnerable can make such a difference in helping to improve the outcomes for our patients. Now, this is such an important topic for us because we know that about 5% of our patients account for about 37% of our ACO expenditures, and about 10% account for about 55% of our ACO expenditures. Now, I like to think about those expenditures as that's somebody utilizing healthcare maybe differently than their peers. So if we can drill into why are they using healthcare, hopefully we can lead to better outcomes for our patients, because oftentimes high healthcare is stressful, leads to other things that cause us to be nervous, worried, and we want to make sure that that patient is able to be as happy, healthy, and thriving as possible. Now, when we're identifying high-risk patients, there's typically 5 things or 5 areas that we'll focus on. Sometimes you'll think about cost and just simply say, let's focus on our most expensive patients. Sometimes you'll think about a high risk score and spend most of your time just focusing on who are those patients that purely on paper from coding look to be a little bit riskier. Sometimes you'll look at a patient that maybe has high spend in a certain category, something like maybe emergency department transportation or ambulance transportation. Why would that patient be using the ambulance as often as they are? Those things that would just cause you to scratch your head and say, you know what, I think we can support this patient in a little bit different way to make an impact. Oftentimes we'll focus on patients with risky conditions. For today's discussion, we're going to be thinking about, all right, maybe we've identified some of those patients that have multiple of those other categories, but most importantly, they seem to be using the emergency department differently than their peers. And how, knowing that these patients use their emergency department differently than their peers, can we best support them? And part of the real relevance or the reason why, as it comes to today's discussion, is the U.S. spends about $60 billion a year on emergency department care. Now, that's about 2% of the total healthcare expenditure in the United States. Now, we're looking at that as kind of saying there's a high number of those claims that are maybe occurring during times that don't seem quite like they should. Maybe it's a clinic visit or an emergency department visit while our clinic is open. Maybe it's an emergency department visit for something that oftentimes the provider would say, I'll see you the next morning. Or an emergency department visit that a provider would say, come on, we could have just squeezed you in. And I know for UPQC we had 106 patients that had at least 6 ED visits in the last 12 months. And the amount of time spent going to the emergency department could be as little as 1 or 2 hours, but it could be several hours spent. So we had 106 patients that spent probably 10 to 20 hours at least just going to the emergency department. That's the type of situation that hopefully we can prevent those patients from having to go through that by finding great care alternatives or maybe more appropriate settings for them. Now for today's discussion, I want to make sure that we kind of level set a little bit as it relates to the emergency departments. Because I don't want today's discussion to come across in any way as picking on or perceiving an emergency department as not being a great or high quality care setting. For today's discussion, I want to build off these, or essentially use these 6 lines as a really ground rules for today. We're expecting all emergency departments to provide high quality care. We expect all clinics or those urgent care settings to provide high quality and high value care. We expect and we know that emergency departments are subject to EMTALA regulations, which means that they're required to see that patient and do that initial triage. We know that an emergency department is an incredible resource, something that when you need it, you want it to be there, and you want it to be able to provide the care that you expect. We know that sometimes it can be difficult to understand the appropriate use of the emergency department. There's times when you're like, maybe I really probably should have went to the emergency department. Or once you leave the visit, you're like, I guess I probably could have went to an urgent care. And I wholeheartedly believe that a patient will always seek out the care that they believe is best or that they believe is most appropriate. So knowing those kind of 6 basics or 6 caveats for today's discussion, let's talk about how we can best support our patients or why we can really spend our time and energy focusing on avoiding that potentially unnecessary care. Now, from my perspective, working with clinicians that are more outpatient based, and my experience as a former hospital leader, knowing that as a hospital leader, I benefited a great deal from additional or potentially unnecessary ED visits. One of the main reasons why we want to think about avoiding those potentially unnecessary ED visits for our patients is it doesn't always impact care coordination the way we'd like, or the way that we typically think about it as an outpatient clinic provider. Those emergency department providers, who are doing an outstanding job, are often very focused on the acute episodic care, treating that patient in the moment when the patient is in front of that provider, as opposed to chronic care, which is maybe diabetic maintenance, maybe helping a patient with anxiety issues, maybe helping a patient to best manage their depression, manage their hypertension, or manage their thyroid issues. We know that cost doesn't always equal value. Sometimes low cost isn't necessarily high value, and sometimes high cost does not necessarily lead to those improved outcomes either. We know that when you're exposed to more health care, such as being in an emergency department setting, you're more likely to get extra health care, and whether or not that's necessarily will help you to be better. And we know that emergency departments can have very unpredictable wait times. The way they're triaging patients, if you're going in for something that is maybe not as severe, or maybe is kind of on the higher threshold for a urgent care or clinic setting, that could cause you to wait quite a bit longer in an emergency department setting where they're triaging based on the greatest need or greatest vulnerability of the patients in front of them. So when I'm thinking about, okay, there's a reason why we're doing this. There's a reason why we want to make sure that we're paying attention to certain patients. It's, from a care coordination perspective or a value perspective, doesn't quite make sense. Now, how can we identify those high emergency department utilizers? I would say my first thing that I always love to try and point to is let's take advantage of any of the claims or digital resources that we have available to us. Things that we can always say, maybe we didn't know about that. First is that Care Direct setting that Care Direct platform that we'll be using and talking about a little bit later today. And Care Direct is a list-based website that will allow you to go in and, based on the claims information that we have available to us, which patients went to the ED in the last 12 months, which patients went to the emergency department in the last 12 months, who's on home health, who has COPD, who has depression. We can also take advantage of the state health exchange. Now, I will tell you, in Utah, the work that Lori does is hands down the best of any of the ACOs that I have as it relates to state exchanges and making sure that the right providers have discharge notifications. If you're not getting discharge notifications from the state exchange today or from that CHI, please contact Lori. Again, of the different ACOs that I work with in different states, no one is better than Lori at helping with this process. So please continue to work with Lori on that. And then you can take advantage of that clinic information that you already know. You have great information in your medical record where you can maybe identify which of our patients went to the emergency department differently than we expected. Or by doing those TCM visits, and again, a TCM visit is a follow-up patient with a clinic after an inpatient stay, a skilled nursing stay, a long-term acute care stay. Bringing that patient back into the clinic to have the follow-up discussions can sometimes lead to the, oh, I didn't realize that you had gone to the emergency department 6 times in the last 4 weeks, 6 times in the last 2 years. And that resulted in a couple unnecessary admissions or things that we probably would have wanted to try and avoid. So take advantage of those resources that you have available to you already today, whether it be those claims or digital resources such as Care Direct, ACO Health Solutions, or that State Health Exchange, or things that you already know, like your clinic medical record, or seeing the patient face-to-face through those transitional care visits. So how can we identify and utilize that information that we already have? So now we've thought about, okay, from our perspective, we know that an unnecessary emergency department visit may not help with care coordination. We know that an unnecessary emergency department visit may not necessarily provide that value that the patient wants. But why would the patient be doing this? And a couple common misperceptions that I came across were, patient believes that the care team is better in an emergency department. In some instances they are. And again, we're going into today's discussion as I believe that every urgent care has some outstanding staff and outstanding providers. And I believe that every emergency department has outstanding staff and outstanding providers. So from my perspective, that care team may not necessarily be better at an emergency department than you will get in an urgent care or in a clinic. Patients will often misperceive or perceive that in an emergency department setting, they're going to have anything that I would ever need in case I need it. So if they decide I need to do lab tests, if they decide I need imaging, at least they have it. Or at least I don't have to worry about delays in care. Well, that's true, but that doesn't necessarily mean it's going to help your outcomes. We'll often see those brandings or those signs for short wait times for an emergency department. And yes, that's true. Sometimes you're going to get really short wait times, but while you go to the emergency department, they also do a level of triage where you may come in with a short wait time but be seen later than someone else because they have more kind of acute or more serious medical conditions. Unfortunately, patients perceive that if they go to the emergency department, they're not going to have to pay. And that's just simply not true. They will likely get a bill, and more emergency departments are starting to expect that upfront payment before care is being seen, especially once that triage has been completed. Urgent care is often perceived as like, how do I even find one of these? We need to work with our practices on what is the preferred local urgent care, whether we have one of our own, or how could we point them in the right direction if there is one available. And of course, the emergency department is going to tell my doctor, my provider, everything about the visit. Unfortunately, we know that's not necessarily true. So how do we make sure that we're educating our patients on that? And what's something else that a patient may not realize? Because we know that patient our care team provider may not find out about that emergency department visit until at the very least several days later. So how can we kind of make sure that the patient realizes that this is going to potentially have gaps in your care that we don't know about? This could expose you to potentially unnecessary testing. An unnecessary CT scan is going to put you at risk for unnecessary radiation exposure. How do we make sure that the patient understands that if you're going to the emergency department, you are more likely to be admitted to the hospital, but that doesn't necessarily mean you needed to have been admitted to the hospital. Certainly, I'm not saying that anyone would admit a patient unnecessarily. Every provider is going to do what they believe is best for the patient in that setting. I'm taking the approach of, as a primary care provider, you may have additional information that the emergency department provider does not have. So you can take advantage of a 30-year, 20-year relationship with the patient to say, I know you, Jane. I know you, Sally. Why don't you come in the next day? I'll see you. I know you. Personally, I believe that an emergency department visit is stressful not only to the patient, but certainly to the patient's family as well. If a patient's family member goes to the emergency department, they're more likely to leave work, leave where they're at, to make sure that they're going to check on mom, dad, brother, sister. We know that not every patient's going to have equal wait times, so educating our patients on, just because it says 0 minutes on that billboard sign by the interstate, that doesn't mean you're going to be in and out of there in less than 15 minutes. And you know that if you come in here, it's going to take about the same amount of time, regardless of whether or not we're able to fit you in or how quickly we can fit you in. Emergency department care isn't always a cheaper option, and emergency department providers are not necessarily always physicians. So there's sometimes that perception of, I'm going to a hospital, I'm going to see a physician, I'm going to see a doctor. You may be just as likely to see a nurse practitioner or a physician's assistant going to the emergency department as you would in an urgent care or in a traditional clinic. We need to make sure we're engaging and educating our patients on, these are things that I think you maybe didn't realize was going on with emergency department care, and one of the things that's great about what we can do and fit you in. Now, that being said, again, I'm not trying to say that emergency department care is not an awesome thing to have available to us. Because certainly there are some really important reasons for going to the emergency department. When our patients are having chest pain, severe abdominal pain, potentially numbness, sudden severe headaches, seizures, high fevers, we need to get them to the emergency department as soon as possible. Those high acuity, emergent, threatening situations, we have to get the patient to the emergency department, or the patient has to get themselves to the emergency department as soon as possible. Again, I'm not trying to say that there's situations where we should ever completely rule out the emergency department. We just have to ensure that we're finding the right care setting for the right patient under the right symptoms. Okay, so now we started kind of said, all right, well, we understand that there's a reason why we don't want our patients to go. And there's probably a reason why the patients are going, and there's just maybe perception issues or they're not quite sure. So for Utah Physicians Quality Care, why are our patients going to the ED? Our number one reason or diagnosis for the reason why our patients are going to the emergency department was type 2 diabetes without complications. Our number 4 reason why patients in Utah Physicians Quality Care ACO were going to the emergency department was nicotine dependence. Those are things that I think as much as possible we'd like to feel like we can probably help, coach, and treat the patient in a clinic setting or educate the patient how to best manage their disease in a clinic setting. Engaging the patient is really one of the best ways to help to avoid those potentially unnecessary or those things that would just cause you to scratch your head emergency department visits. So this is the what. This is the patient is going to the emergency department. We know that we had 953 patients that went to the emergency department because of type 2 diabetes without complications. That's not necessarily why the patient went. Now, a diagnosis of an emergency department visit for type 2 diabetes, that's something that's identified as a way to make sure that we're getting paid. That's something that's identified and determined to be a diagnosis after other causes were sort of ruled out. But that's the what. That's not necessarily the why. Because again, the why is what caused the patient to go. The what is the definition that was identified later. But those emotional feelings, physical feelings, potentially knowledge gaps. Maybe I thought this was the best place to go for my care. How can we best support our patients to address those symptoms and reasons? Because working off a list of just diagnoses can cause us to be frustrated, question the patient's judgment. We need to engage the patient the right way to make sure that we're able to support those emotional feelings. Physical feelings help the patient to understand that if you feel this way again, we'll see you the next day in the clinic. Or if you feel this way, you better get to the emergency department as soon as you can. To build off our last webinar, we gave 3 examples. Now, all 3 of these examples were real patients that we had worked with. Real patients that I had worked with one of my ACOs, or one of my team members more directly had worked with these 3 team members, or these 3 patients. Now, obviously their names were not Nellie, Stan, and Kathy, although I'm sure we could all think of a Nellie, Stan, and Kathy that we've interacted with in our own clinics. Nellie is somebody that had been to the emergency department 10 times in the last year for non-emergent reasons. Nellie started to get nervous, get worried, and she felt like the emergency department was the right care setting, so she went. And one of the things that the emergency department, or that the clinic did when they started to dig in a little deeper, was they said, all right, well, how can we, reach out to Nellie in a different way and figure out what's going on? And by enrolling Nellie in a chronic care management program, they were able to see her a little bit more often, talk about the things that were going on as it was related to that CCM care plan, and reduce her anxiety levels. Mr. Stan was somebody that kept going to the hospital because he did not control his A1C and his glucose levels. So the clinic started to identify, this is an issue. How do we support it? Because you shouldn't be getting your lab tests done when things are out of control and you're in the emergency department. How do we catch this and work on this sooner? So the practice began seeing Stan once every 8 weeks, and then once every 3 months they would do an A1C check on Stan, because they know that Medicare pays for it once every 3 months. So how do we do this A1C check a little bit more often? Now Kathy was somebody that needed to have that additional encounter to talk through her medical conditions. And for Kathy, again, Kathy was a high home health utilizer, and they decided to enroll her in CCM. Kathy wasn't necessarily an ED utilizer, so we're not going to spend today's discussion focusing on Miss Chatty Kathy. So that was 3 examples, or more importantly, 2 examples directly related to the emergency department of how engaging your patient can make a real difference. So the things that I think are important is, how do we make sure that we're contacting those patients to discuss the reason for the visit? How do we make sure that we're contacting the patient to develop an action plan? Because everything is designed around, how do we best support this specific patient to maybe be a little less vulnerable, to help that patient to really own their health, to manage their health, and to feel better about their care. And how do we identify opportunities to support the patient? So for Utah Physician Quality Care, if you feel like you're hitting barriers, hitting roadblocks, identifying those community resources, please reach out to Brian. He's happy to help with this, and this is really in his background and his skill set to make sure that we're supporting those patients that are most vulnerable. So one of my first steps, again, is that actively contacting the patient. So when we bring the patient into the clinic, now first we may have an office assistant or a nurse call that patient to schedule those follow-up exams. A hint for, or a tip for any of those follow-up visits, anytime you can reference back to the primary care provider. I'm Adam, I'm calling from Dr. Johnson's office. Dr. Johnson wanted me to give you a call because he saw that you just went to the emergency department. That's much more powerful than, I'm Adam, I'm from a local clinic, and I would like you to come into the clinic. We need to make sure that the patient understands the importance of the physician or the provider wanting to see the patient. We could consider doing a mailing. We could consider rolling a patient in chronic care management if it's appropriate. I would always say, if you have a patient that goes to the emergency department for things that you feel like as a clinic you can have influence over, now I would typically point to some of those ambulatory sensitive conditions, like patient goes because of dehydration, pneumonia, UTI, COPD, CHF, or diabetes. An admission or an ED visit because of one of those reasons is often something that I feel like we can maybe redirect or focus on in the clinic, and how can we bring those patients back in to support them? When you bring that patient back into the clinic and you're having that face-to-face encounter, I would review kind of what caused the patient to go to the emergency department or why they felt like they needed to go. Because again, the diagnosis may not be the events, the feelings that caused the patient to go to the emergency department. We need to always make sure that for those higher utilizers, we're encouraging the patient to contact the clinic. That's especially important during clinic hours. If the clinic is open, it's 2 o'clock on a Thursday, let's make sure that they give us a call, because hopefully we can squeeze them in yet that day or maybe even the next morning. We need to make sure we're educating the patients about ED avoidance, or again, those potentially vulnerable situations where there's those knowledge gaps for the patient where they maybe don't know the great care that we're able to provide within the clinic or others in town are able to do. If your organization has some sort of a 24/7 call center or after hours number, always give that to the patient or make them aware whenever possible. If you would like to think about chronic care management for a patient, now is oftentimes a great opportunity when that patient is most vulnerable. If you're somebody if your clinic would like to do chronic care management, but you don't quite feel like you're able to do it today, please reach out to Brian or myself. We have a company that we work with that it's a kind of Imperium preferred vendor, but we do not benefit in any way financially. It's just we went out, and because we work with so many different practices, we picked a couple that we thought were good, or picked one for a couple different areas, and we'd be happy to connect you with ChartSpan to make sure that you're able to meet your CCM needs if you're not able to do it today. And I would always consider, when you get those patients that are almost like frequent flyers, let's schedule them for that follow-up meeting. Schedule them for that follow-up visit. That might be one simple thing that can help with the patient to reduce their anxiety. You know, sometimes we feel like, well, I'll wait because I have this appointment in 2 weeks. If we put that appointment down in the book so that the patient knows in 2 weeks I'm going to come back into the clinic, they might be less likely to go to the emergency department for something that we felt like, you know, if you knew you were coming in a week, we could have focused on it there. So those are great things to think about in terms of bringing the patient into the clinic. We haven't spent as much time today talking about extending your hours or providing just pure urgent care. If urgent care is an option, I think the world of urgent care, and I would promote it all day for the right settings. If urgent care is not an option, either within your clinic or within your community, you can think about when is it appropriate to maybe think about extending hours. Maybe extending hours on 1 day or 2 days during the week, just to make sure that we're able to fit the patients in. Always consider same-day scheduling. That idea of the more patients that realize that we can see them whenever possible definitely makes a difference in reducing your emergency department utilization, because patients will understand, you know, if something comes up, I can be seen by my provider. I don't need to worry about is the emergency department or is the hospital going to have all of my labs and all of my information. I know that the clinic will have it. As a clinic or as a care team, you may want to think about how can we best utilize our mid-levels for sick visits or those ED follow-ups. Actively managing that frequent flyer or those high utilizing ED lists to think about, okay, we have claims information that's different than we otherwise have. How do we kind of extend the role of the clinic, extend our influence onto our patients by taking advantage of extra data sources that we have coming into us or extra information? If your clinic is able to offer labs, imaging, or other IV fluids, that can be a great way to get the patient's confidence up, say by saying to the patient, why don't you come in once every 3 months and we're going to do an A1C check. Now we can do a chest x-ray right here. Let's do an ultrasound scan today. Or, you know, we can get you hooked up with some fluids right away today. That way you don't feel like you're going to be vulnerable for the weekend. The last thing we're going to discuss today is how to get in and navigate Care Direct. So for many of you, you would have been given access already to Care Direct. If you did not, please contact Brian or myself and we'll make sure that we get you set up. And if you need any username or password help, Brian will be a great resource to help with that. When you're navigating Care Direct, look for those manila folders on the left side of your screen, and opening the folders is going to be the best way to access and see a few different sets of information. When you're in Care Direct and you've selected the report that you're most interested in, you can filter by provider to make sure that you're seeing just the information you'd like to see. And then you're going to have the ability to export those reports as a comma-separated value field or comma-separated value document. Think about that like just an Excel form. Or most importantly, you can download and export that as a PDF. Downloading that as a PDF is going to ensure that you can print it, modify it, write on it, and share that information within your clinic. When you click those export buttons, it's going to pop up that blue bar in the middle of your screen. By doing that, it just lets you know that it's kind of working and it's getting there. And then once you click that download, you'll be able to take and use that information for yourself so you don't feel like you got to sit in front of the computer to best support your patients. A couple nuances with some of the Care Direct reports. It's only going to show living patients that have not opted out of ACO data or opted out of ACO data sharing. This is going to be a little different than ACO Health Solutions because sometimes those patients will still be in ACO Health Solutions. The inpatient or the ED visit reports, because that's what we're most focused on today, is going to show encounters over the last 12 months. So when you're in CareDirect, you may want to make sure that you click on the date of the encounter to best sort by encounter, or click on the patient's last name to support by those patient names. Kind of what's next? Brian is going to be sending out lists of high utilizing patients to support you in those review sessions. And Brian is going to be reaching out to you to best support you in some of those review sessions with your patients. I would encourage you to reach out and work with your patients to identify kind of the whys. Learn why the patient is going in. Learn what we can do to help the patient by learning kind of the why behind it. And then if you need Brian's help with the kind of the how component, we're happy to help with that. Brian can help with any CareDirect passwords. And if you're interested in CCM services but you're not able to do it today, we're happy to introduce you to ChartSpan. I have one of their leaders' phone numbers on my cell phone, and I can pass that along to you, and we want to make sure that you get the support that you need. Thank you very much for your time. Again, as always, if you have any questions, please reach out to Brian, Lori, or myself, and we're happy to help you however we can. I hope you have a great rest of your day, and thank you for spending some time with us to learn a little bit more about how do we best support those most vulnerable patients.